So, I am chairing and presenting at the same time, so bear with me while I get my catch my bearings. It's a real pleasure to really interrogate some of the issues I've been talking about already in more detail. And we have some case discussions, and I'm going to introduce our panel members first, who are esteemed and experienced in thinking about vulnerability in the context of care relationships, both in terms of adult safeguarding, but more broadly in terms of how we think about what caregivers and care recipients need when they are engaged in caregiving and the kind of supports and duties that might apply. So I'm very pleased to welcome on my right-hand side here Lu Wei-Leng and Dwayne Liu, both of whom participated in the Dementia Singapore Voices for Help program in 2022. I think that's right. Voices for Hope in 2022. They're also care partners, that's right. Dwayne, to my right, was a former German-speaking leading steward with our national airline for close to 30 years. Welcome, Dwayne. Thank you for joining us. And Wei-Leng, you work with various multinational companies in supply chain management in Singapore, I think. That's right. And to my left-hand side, I'm very pleased to welcome Tabitha Ong. Tabitha is a very experienced member of social services and statutory protective services in Singapore. She's currently leading an adult protective service, an APS, within the Ministry of Social and Family Development. Key contributor, therefore, to managing vulnerable adult abuse and family violence type cases. And finally, on my far left, it's a pleasure to welcome Mr. Stephen Chan, Director of Care Services at Dementia Singapore. Previously the Centre Manager of the New Horizons Centre in Tampines, and the Head of Caregiver Support Services, with a vast range of experience in the eldercare sector, most commonly as an occupational therapist, I understand, Stephen. Thank you. Well, pleasure to have my panel members with us. We have a number of case scenarios to go through, in fact, two. We're going to start with the first one. I will read out this case, as we did before, and then I'll turn with two questions to the audience first, and then to my panel members. I don't have it in front of me, so I'm going to turn around. So we have a question: who is a vulnerable adult at home? Thank you. That's great. Thanks so much. John Francis is an 81-year-old man who recently moved into the home of his son, Ian, daughter-in-law, Jenny, and their two children. Whilst increasingly frail because of his advancing age and dependent on his family for support in daily life, John does not have any other illnesses. Jenny has become unhappy with her father-in-law living with the family. She feels that her family do not enjoy enough time alone together. When Ian has gone to work, she locks John in his room and threatens that she will tie him to the bed if he tries to leave. John's daughter learns of what Jenny is doing. When she takes her father to a routine consultation with his GP, Dr. Tan, John's daughter raises the matter after her father has left the room. Dr. Tan refers her to a medical social worker, and she receives help to submit a report to the Social Services Bureau requesting that her father is protected from Jenny. An assessment of John's situation is undertaken under the Vulnerable Adults Act, even though Jenny was initially resistant to allow the social worker into the home. During the assessment, John is frank with the social worker. He says, "Yes, Jenny makes threats and stops me leaving my room. I don't like it, but it's a small price to pay to have my favourite child and my grandchildren close to me in the last few years of my life." So that, I hope, is a good case to get us to starting to think about the manifestation of vulnerabilities in this kind of home care context. The second case will be very different, but this is a start at least. We have two questions that I'm going to pose first to you, the audience, and then to my colleagues around this table. The first question is the following: is John a vulnerable adult in this case? And second, Is John being subject to abuse? Would anybody in the audience like to express a view first at the microphones? If they have an immediate inclination about this scenario, how would you think about those two questions in this case? Anybody want to volunteer to put forward an initial view? No trick questions, it's just an ability to hear your thoughts and your views on this kind of situation. Thank you very much.
Can I ask for more information, though? I want to know why he was locked in the first place. Was he destructive? You know, why did the daughter-in-law lock him up in the first place?
As always with these clinical ethics type of dilemmas, information is limited and we always want more. That's a common lesson, I think. It's not clear. And maybe your point is that we need to find that out in order to respond appropriately and to understand precisely the nature of the vulnerability in play, what needs to be done, and how we think about whether abuse is in place. We just don't have that information. So maybe that's just a basic piece of information that we want to find out in making further progress in this situation. I think that's a very reasonable question, and I'm sure Steve and colleagues will have more to say about that. Anybody else want to come in before I hand over to the panel members? Yes, please.
Actually, Mr. John is 85 years old, also is elderly, right? Also affecting his emotional and also touching his dignity as well. When daughter-in-law locks, also safety issues. So his two-way concern, also his emotional threat as well, the safety issues as well. So either way to be settled for this care.
Thank you very much indeed. So you have elements of John's presentation that are relevant to deciding whether he's vulnerable in this case, I think, if I understand correctly. His age, his advancing age, and also basic observations about his safety that are being threatened in the family context. Is that right?
Yeah, but we don't know the case that his psychological issues, anything like he's on any controlled medicine or what. So maybe timely manner, which is not served as well. Behavior issues, we don't know yet this case, but emotionally is a threat for Mr. John also.
I see. Thank you very much. Yeah, that's a really helpful way to think that through. I'm going to turn now, if I can, to Stephen to comment on those two questions, and perhaps responding also to the audience comments, if you could.
Yeah. Okay. Just responding to the question that the First Lady who asked the question about don't have enough information, same with me. Don't have information for me to really, determine whether abuse really happened. But I think, and then same as the lady over there, you need to find out more information about what is happening, what is the culture, what is the values, what is the daily habits like in the family, within the family. Dr. Ng Wai Chong, I understand, talk about person-centered care. Everybody has some uniqueness, different set of values, experience, worldviews. And I don't know what is the worldview of John in this case. Yeah, but I mean, in my own opinion, I think that John is in the category of vulnerable adult. Whether he is being abused, there's a big question mark. Why I say that he is vulnerable is because he is reliant on the family members for caregiving. And then I think that there is certain vulnerability. But at the same time, he is very aware of what is happening. In fact, he did mention that it's a small price to pay to stay in the room for a while in order to be close to the grandchildren. So I think, again, it is not very clear, but I mean, as we investigate, find out more, probably the clarity will come.
Thank you very much. Stephen, I want to emphasize your account of him being vulnerable there by reference to the kind of relationship context, particularly you mentioned, isn't it? Rather than sort of relying on the fact that he's 81 years old, frail and of advancing age, it was obviously the kind of the scenario, that relational scenario that you were very much highlighting there, which I think is an important observation. Thank you. May I hand over to Dwayne and Wei Leng? Would you like to add anything to those points? Please feel free to go in turn.
Is this working? Okay. Maybe you want to. It's
okay. Yeah.
So, thanks, Mikey, for the little introduction. I'm Dwayne's care partner, slightly older sister. He's my younger brother. So Dwayne was diagnosed with young onset dementia December 2021. So a person with dementia, maybe not all, but they say as what they see. So this case was, when I reviewed with him, it was very straightforward. His answer was very straightforward. What did you say about this case? About this job? Is he a vulnerable person?
He's not he's not. He was locked because he was because of the what do you call it? Because of the father. They locked the. He's invulnerable.
Why is that so?
It was because he wants to have the relationship with the sons, and the grandchildren, yeah. But by locking them is he can stay in the room. Yeah.
But would you, if I were to lock you up, okay, what do you think?
I wouldn't be locked in the room. Yeah.
So maybe I just add a bit. When we reviewed this, to him it was very straightforward. It's a vulnerable person and it's an abuse because it's like being jailed at home. So when we look at this case, we did not think further as what others were asking a lot of questions. It's not, if on the surface it's not ethical to be constrained, and we believe, at least I believe, there are other ways to handle this matter, like education for this daughter-in-law. And then maybe I will also ask Tabitha, because you're very into this adult protection, because you can say it's overprotection because of safety, like the lady was saying, could be because it's safety or for selfish agenda. But the question is, where do we draw that line?
Okay, hi. Okay, I'll take this in two levels. I think the first point to make, it is clear that this is not acceptable, and there are concerns, when such practices is being carried out against John in this case. I guess from a protection lens, we usually do not just decide like, is this abuse or not abuse, but we see it on a continuum in that sense. So the level of protections usually, we look at it we kind of stratify in terms of the level of risk and the level of concerns in that sense. So if this happens in Singapore, and if this is kind of a real case in the local context, there is a framework in Singapore in safeguarding or protection of vulnerable adults, which means that there is different levels of intervention. I will call it like the primary, secondary, and the tertiary. It's very much how healthcare would think about level of intervention. So at the primary level, really, there will be agencies in the social service sector, healthcare service sector, who are touch points with the seniors, and the vulnerable adults. And they usually will be the ones who who are very, very familiar with the seniors and their families, and they usually know what's going on, and things like that. And more often than not, they are also usually the ones who flagged up cases when, after many tries of trying to work with the family members and nothing improved, they usually will be the ones who flagged up the cases, either to us or to the next level, the secondary level of intervention, whereby there are specialist centers in the social service sectors. They could be the protection specialist centers who deal with families who face a higher level of protection concerns that we see, and they reach out to them and do a deeper level and more intensive level of intervention. And the protection specialist centers, sometimes they also have limited statutory power that the Ministry of Social and Family Development delegates such statutory powers to them, and they could intervene at that level. The adult protective service that I'm currently in, of course, we deal with the highest risk case. So we're looking at really very severe abuse on the vulnerable adults, or sexual abuse, those that really it calls for statutory and government very invasive of intervention, because our of intervention actually brings a lot of stress to the families as well. So it will only be used as the last resort, and we are very clear that our involvement actually sometimes do actually make so-called damage or strain the relationships within the family further. Yeah, but because safety is very much it's the top priority, and in such families, we are seeing that dangers are pretty much imminent and serious, so we will have to intervene in that sense. Yeah, so I think, coming back to this case, I don't think this is a case whereby it will escalate so quickly unless we have other information to show that John is very much at immediate and severe danger. But I would say that it's definitely of concern. Definitely somebody, a professional will have to probably at a community-based level, have to speak to the daughter-in-law, to highlight and flag that this is not acceptable, and with the view to help improve the situation by trying out other strategies, or talking through addressing the relationship issue, or even the grievances that the daughter-in-law might have, with the view to improve that and to prevent an escalation of such inappropriate practice, to get worse and then to impact on John. Yeah, in that sense.
Thanks, Tabitha. I'll hand over to Stephen, who wants to add something, I think. Please, Stephen.
Yeah, I just want to respond to what Tabitha has commented. I think it's very true. Oftentimes, in Dementia Singapore, we do provide home-based psychosocial interventions of service. So when we go in, we have to assess in a very system level rather than looking at whether John is subject to abuse and then don't look at the broader picture. Even you call in adult protection services or even activate personal protection order, PPO, whether like what Tabitha says, that if you pose more harm to the whole family, then good. And also the risk that is involved. Of course, if risk that is involved that John is imminent risk, then it's quite clear-cut, but oftentimes it's not that clear-cut, that we have to have a balance of probability. Sometimes choose between the devil and deep blue sea, which one is a lesser of an evil. That is our approach. But for this case, the daughter-in-law actually, first off is going in as a caseworker to do an assessment as a neutral party. I don't have any preconception that who is the aggressor and who is the victim. Go in and then build that therapeutic and trusting relationship to begin with. Who knows, maybe the daughter-in-law has a lot of needs. And then the needs can be easily met at the existing community services. They have counseling services, even some daycare services that give respite. And then even if you are talking about financial burden, there's a lot of resources as well. Connecting the daughter or the family in the support network. And then looking at the case study, one thing that is really missing out is how come the husband is not in the picture? Yeah, so there is a big question mark. And then there's a lot of fact-finding that is needed before coming to the conclusion, like whether abuse and neglect really happened.
Thank you very much, both of you, for those remarks. I think I picked up on three really important points there that maybe just worth reiterating. One of them, Tabitha, came from what you said, just the care that's needed to, as it were, define the severity of the problem, and perhaps in a very dynamic way, and then instigate different kinds of responses in line with the gradation of risk, perhaps, that goes on. That's quite important. It's a very pragmatic, I guess, responsiveness to that. Also very interesting, I think, how we can think that the protective response, the safeguarding response, could actually be worse than, or at least as bad as, potentially, the problem that we're trying to respond to. That our protective impetus could be harmful if we don't calibrate it and work in the right kind of way. I think that's really important. And I think finally, that the targeting of the protection response can't just be the person who's being abused or at risk of abuse, but should be the entire setting, as it were, the relationships that are in place. The potential abuser, we might think in this case, or indeed other absent members of relationships. So that kind of idea of management of relationships seems like a really important part of an appropriate response, as opposed to I'm going to target this person, I'm going to protect them. You actually have to work with the relationships that we have. Thank you. Good. So we're already, I think, moving on to our third and final question, but we'll segue into that and we'll keep the conversation going. What further steps to protect John would be ethically justified? Now, I think, Tabitha, Stephen, you already started thinking about that in terms of your articulations of responses. We have this legislation to invoke, and I take it that that's a last resort, and the idea of using the court would not be perhaps the first port of call in a scenario like this. But before we come to those kinds of questions about the role of the law and the role of the court, maybe I could pass back to Wei Leng and to Dwayne and ask you, what would you think would be an appropriate way to protect John? If you found yourself in a scenario like this, or if you observed this kind of scenario, what would your thought be about taking steps to help John?
Okay, it depends on how much I know the family, for one. And I think there's a cultural thing where we say the family affair, sometimes we try not to step in, right? But then, maybe before I answer that, I will give you an example of our mom. She's diabetic, and last year she fell down while she was walking to the bus stop to take a bus, and it was a bad fall, and in the end she had really bad bruise on her face. And because of her health conditions, she goes to the GP polyclinic every 3 months. But she refused us to go accompany her, so she goes herself. And then when we saw her with the bruises, and then she said, you know what, it's very interesting. I saw the doctor. The doctor never asked about my bruises. So, just treat her for the diabetic. So just now we talked about polyclinic, about GP, getting to know GP, but our parents are going to a polyclinic for reasons of finance. Okay, And the thing is, would it be right that the doctor also start questioning? It could be abuse. She could have been abused, because we have heard of story where the vulnerable adult is hit by, when they shower them, those who are very dependent and are hit by this case is a helper who hit the adult with the shower thingy, okay? Yeah, the shower. Yeah. So would it be right for public, putting aside the cultural restraint, would it be better if we raise this to a professional? That's where the professional come in to ascertain what is really the cost, and that's where John being a willing victim, is it acceptable? And then of course the protocol of where, if I'm willing to be subjected to being locked in the room, who's to stop me? Is a willing victim, is it considered, self-harm you were talking about? Yeah. So in this case, I think the professionals have to be roped in. When help is needed, I think we should ask for help and then raise the awareness and be more inclusive in the sense that you take action as well. Not just, I know this is happening, and maybe chatter among neighbors, I don't know. So that's my take. We rope in professionals. That's why the inclusive community is very important.
Thank you, Ellie. Yeah, Dwayne, anything you'd like to add? Anything more you'd like to say?
I think it's they sometimes they did not want to answer to the father. That's why they sorry. The son, the daughter. Yeah, sorry.
Yeah, that's really helpful. So, thank you. Yeah, thank you both. Really interesting questions. Maybe Stephen, Tabitha, you could comment on this. How do those reporting avenues tend to work? We can imagine that people want to keep this very private. Very difficult to become aware of it. There may be multiple possible reports that come in. How do the reporting mechanisms and the sort of protective pathways play out when it's such a private matter in this kind of situation?
Yeah, I think first off is look at John, and are there services outside of the family that can put in place to support John better? I can think of a daycare center. I can think of, sometimes you have elder seat services to go in to do activity engagement with John. Whatever services that is relevant and palatable to John, and then with John's consent, it can act as a monitoring mechanism. And then this serves as a deterrence already. And then hopefully with the services, and then with there is a third eye, so-called, that is monitoring the condition, because I think most of the services, if it's established services, do have abuse, neglect protocol in place. If they detect something is wrong, they will have an escalation framework. So that can be further steps to protect John, and then hopefully it's ethically justifiable. But I can think that if it's helpful, beneficial, and then consented, and then it's something that John wants to, I think we have covered a big part of the ethical justification why these services should be in.
Thanks very much, Stephen. One of the I guess the stark features of this kind of case is that John does not want, or does not appear to want, help. Right? He's very clear that he's acknowledging what's going on, and he gives a clear rationale for why he doesn't want help. Now, I guess that would make it firstly very difficult to necessarily even know about this. Do we even find out? Because if John is himself wanting to resist assistance, he may want to keep it as private as possible. But secondly, and this comes back to a point you made, Wei Lang, is he sort of engaged in a sort of act of willing self-harm? And how do we make sense of what he's saying and what he's doing? Is this a common response in the adult protection world? How would you work with John in the face of that kind of response? Either of you could come in on that, please. Please.
Okay. I mean, Michael, it's not making life any easier for me. So I think first off is, again, just now I missed on one component, maybe I touch on it a bit later. When we go in, there is always this assessment phase when we need to find out. And then from there should be something that is valuable to John. And then hopefully, they're valuable to John, and John is agreeable to it. But I think that the main key thing is building a trusting relationship. But Michael just now was saying that John don't even want to speak to the person or how the person come to us. That's where, I must confess that I'm inexperienced, because most of our services is referred to us, or they take the initiative to call a helpline and make known to us. And then if there is really abuse happening, and then there is nobody reporting it, only through observation by neighbors, passerbys, or other family members. So then, in this kind of scenario or situation, they don't even want to consent for service. That's a tricky part. When there is no consent for service, like what Wei Ling says, a professional, very hard for a professional to come in, except adult protection officer can go in and then to do further fact-finding. Hopefully that part. But again, we are focusing on John. There are also services that can focus on the daughter-in-law, Jenny, daughter-in-law, and what frustrates Jenny? The question I have is, what caused him to have such frustration that she is acting out? And then assuming that she has mental capacity, and then she is willing to explore resources that is available that can reduce her sense of frustration towards John. There is another angle that we can go in to help sort of the family members to lessen John's vulnerability in the community. For example, counseling service. If Jenny thinks that she wants more time, will there be a neutral party in a way that makes some arrangement with the family members to have some short stays over with another children? A daycare center, in a daycare, John can go to a daycare center and then give some private time to Jenny if there is her needs. But first off, we have to find out what is Jenny's needs as well. And then when either towards John or towards Jenny, we can support the system as a whole, still keep that, the family knitted together, rather than the whole family has may be broken down by calling in law enforcement.
Thank you. Tabitha, anything to add to that in terms of, I guess, how we would respond in the face of what John is saying? Is there a sense of powerlessness, or can we take the route towards Jenny, I guess, in those situations?
Right, thanks. So the challenge about what we call intrafamiliar abuse or neglect situation, which means it happens within family context, is way more complex and challenging when it is extra-familiar, right? Because there's relationship at play here, and there's certain level of trust, that's being so-called violated as well, but there's still some wanting the family ties and stuff like that. So it is challenging, and just now, Mikey, you asked about whether is this common that John refuses like kind of help. It is very common. And I think one of the classic case you have brought up was just now earlier in your presentation, the one that that went to court and, you know, yeah. So coming back to John's case, I think the approach is really just to echo what, you know, was being shared earlier. It is about building relationship with him. It's about building the trust between the professional as well as the, with John, as well as the family, you know, to kind of have that understanding and trust to know that the professionals are coming in to help the situation, but not make things worse, you know, in that sense. So even in adult protective service, right, we also don't take a very forensic or a criminal investigative kind of approach, because that wouldn't work in that sense. And if we take on like a criminal kind of investigative approach, right, it really doesn't help, you know, our work in trying to stop the abuse and break the cycle of violence in that sense. So we also have to take an approach whereby that is strengths-based, that is trying to find out from the family actually what worked for them and what went wrong in that sense, instead of just keep focusing on like what went wrong, you know, in that sense. Because we also have to acknowledge that for many days the families can provide adequate and good enough care for the VA. And something happened and we want to prevent that situation from happening again, you know, in that sense. So I guess there's a lot of relationship building that needs to be done, trust building, both in terms of the VA as well as the family system. And I think you also brought up earlier that it's not just working with the VA, but also the whole family system or in his network, you know, to help keep him safe in that sense, yeah.
Thanks, Tabitha. I think that point about not taking an investigative or adversarial approach seems really important, doesn't it, here? I guess that might be one reason why the court is to be avoided at all costs, because it sets up an adversarial set of relationships. Thank you. Over to the audience. Please, sir, come in.
Thanks. Hi, my name is Punchen, and I'm a psychiatrist with my colleagues from the Institute of Mental Health. Thank you for a very rich discussion. I'd just like to ask the panel, if I change a little bit of this vignette, where everything is the same, but instead of the 85-year-old adult being locked in, it's the opposite. The family locks themselves away from this 85-year-old person and takes away the only two things he values in life right now: access to his favorite child and favorite grandchild. They just lead their separate lives. He's well cared for. He's got a maid or migrant helper helping him. He can eat whatever he wants, do whatever he wants. He just has no contact with the two most important people in his life. As a result, he's recurrently suicidal. He keeps coming to my institution because the social care services keep picking up on his acute suicidality. And I will tell you, we will never make him feel happy. His hopelessness is real. Then do the answers to these three questions stay the same? Is he a vulnerable adult? He is depressed, clinically depressed, recurrently suicidal, literally hopeless because he can't get access in the few years he has left to the two most important relationships he wants to maintain because of the daughter-in-law, I suppose. Are the answers to this exactly the same, and is the approach discussed so far entirely applicable or not? Thank you for listening to this strange thought experiment.
Thank you. That's a really nice case comparison you brought in there. Anybody like to have a go at responding? I can't really hear. Because of the echo, yeah. So let me just check to make sure I can share what I heard. So see whether this is correct. We're imagining we're changing two features of this case. I think John has a depressive illness. Is that correct? And he is being constrained by his family, stopped from having contact with them and his grandchildren.
Right. The family locks themselves away from him. He's not locked in the room, but he doesn't have a relationship with his favorite son and favorite grandchild. And so the family has locked themselves away from him. He's well cared for with a personal domestic helper and all the food and lodging he wants, but he doesn't have those two things. Yeah. And then because of that, he's depressed and suicidal and keeps getting admitted to my institution. Are the answers to these questions the same? I apologize for the echo. It is quite strong.
It's not your fault. Thank you.
Yeah, okay, I think precisely just now, like what, when we go in and then when we evaluate the situation, it has to be quite a holistic view of the dynamics, the preference, including especially John's preference, understanding him, understanding his concern. I think there is, he made known to himself that it's a small price to pay just to be close to the grandchildren and favorite child. And I do agree, what is the alternative? Is John is being taken away from that environment, what will happen to him? I think as a psychiatrist, probably you may have more experience in this area, and it may potentially cause more harm than good. So then the assessment, the neutrality, the building of therapeutic relationship to see what John really wants, and then at the same time also to build that trusting relationship to tell Jenny that when we come here, we are not citing any other parties, and then but to put in the support structure in place in order to support the family members. I hope that I've answered part of the question.
Yeah. I think it's a really interesting and important question, because I take it that what you're trying to achieve by asking it is to show how the safeguarding might not be safeguarding somebody from harm or the accumulation of a negative care outcome, but the denial of something that the person really values. And do we have a stronger justification to intervene because of just that fact, that they're being deprived of something that they fundamentally value, even if life is otherwise very good? My own view is that we have a clearer rationale for intervention, but that moves us quite a long way from the kind of legal framework that's in place.
I do have a practical reason for asking that. So if in this scenario, and this is my patient, and he's being admitted for the 3rd time this year, can I call Tabitha to go and sort things out? She can't hear me. So if this happens in real life, and this person is admitted 3 times in the same year to my hospital, and I've seen guys always suicidal, can I call Tabitha to go to their house and sort things out under the BAA?
Thanks. I think the justification for intervention is there, but to use the law, in fact, when you were sharing that case, I was running through in my mind what acts we could actually pull out for this, But to use the law, I think it's still some way to go, honestly, yes. Because, it's the justification, the case will need to be built up, and I think there will still be quite a long way to build up such a case. That's not saying that VA doesn't cover emotional or psychological kind of abuse, but it's just that it's quite clear that the justification has to be strong and the threshold has to be fulfilled legally, in that sense. Yeah, but that doesn't mean that professional intervention cannot take place. Yeah.
Thank you, Tabitha. We have come to the end of our first case discussion. Plenty more time to talk about these issues in more detail and draw on the wisdom of our esteemed panel. So 30 minutes for caffeine, and then we'll be back here in the hot seat again for the second case. Thank you.